This going. So welcome everybody to the December meeting of the Dental Codology Insiders, our mastermind. Very honored and thrilled that we have Dr. Susan Maples with us tonight. And thank you, Lucy. I just see Lucy just coming in there. Lucy Conrad was at the AOSH meeting and she connected Dr. Maples with me, although our paths have crossed many, many times. Anyway, and she is going to be talking to us about the HPV oropharyngeal cancer epidemic. And I love the second half of this title. It's our turn to talk and act. And that's what this group is all about, action. Of course, we do offer AGD PACE credit. And in order to get that, please put your full name in the chat box. Although that will be changing. I've got some exciting announcements for some changes that are happening. Again, we need your full name. With that exciting news is that Dental Codology, of course, that brand, as you know, it's about charting our future, not just waiting for somebody else to figure it out for us. So the future is now. And in the Dental Codology brand, we have three parts of that umbrella. We have my speaking and, of course, the books. And by the way, you get as an insider, you get 40% off the books. So think about that. Maybe a nice holiday gift for somebody that you work with. And then there is the exciting news that's happening with the Learning Center. The Learning Center that we had previously called the Insurance Navigator, it's evolving. One of our fellow members and, of course, expert, Kathy Forbes, came into town 2 weeks ago, and we are developing more online curriculum and what we're calling it medically necessary CDT procedure coding for clinicians, the why behind the choices. We're going to do a lot of if, what, then, and we're going to give some of the basics to learn about how to do the using medical codes on dental claims, as well as preparing what you need in the way of determining medical necessity for whether you are submitting dentally or medically. So more to come on that. We're going to have some exciting changes in the Dental Codology Insiders portal tonight. My tech people are putting all the pieces in places to go live now. You might have already gotten a message, but it's not live yet, but you will be. One of the things, of course, as an insider, you're always welcome to is the Mastermind. And today, Lindsay Hill updated the calendar, so we have the dates of all the masterminds in through June of next year, as well as the subjects as we get them. Very excited that we do have Siobhan Healy next month, one of our implant experts and one of the ones that was a real mover and shaker with our submitting the codes, the submissions for implant maintenance. She's going to be talking to us about peri-implantitis and what issues that we can deal with both for our patients as well as for ourselves. So as you can see there, that's set already for the 14th of January, and that is a Tuesday next time. As we have done in the past, we rotate these Monday through Wednesday. That was what you voted for way back when we first got our group started, that we do these on a Monday, Tuesday, or Wednesday evening, and we do them anywhere from 6 to 8 o'clock, depending on where the speaker's located. And since Siobhan, like Dr. Maples, is in the Eastern time zone, we're doing 7 o'clock. So also there'll be a new Smart Brief. That's our monthly newsletter that it'll have a new format when it comes out on December 23rd. I'm excited about that. I haven't even seen it myself, but we'll have a new format. Try to bring you the news that is about how, again, we can shape the future. I hope many of you looked at those articles that I put in last time and the links for artificial intelligence and how artificial intelligence has a role that is playing already in dentistry and how much more it's going to shape dentistry in the future. This is the way you've been seeing the Dental Codology website for for a year now. Well, it is going through a major upgrade at this time. On this site, we'll still have the events, the books, the blogs will be over here, but other things are moving to different places. One of those is that we have a new page for our membership for people to join. Also, what will be happening in the next few weeks is we will be having different levels for you to choose from membership. Don't look at this. This is not the membership levels. This is just something I grabbed off the internet to talk about how it is that we're going to set it up, because we want this group to fit who you are, what your needs are. And so there'll be different membership levels that you will be able to choose from when you renew. You also will have your personal member page. Now, what a personal member page will have, it will have some of the, all of the different options that you have, as well as whatever else you've chosen. So it'll be one place where you can go to get all the information that is appropriate for you. A lot more will be explained as we move forward with this, but I'm really excited about the opportunities that we have, that we found somebody that's really getting this thing together for us in the way that we visualized for a long time. I want to particularly thank Lindsay Hill and Patty Beeson for helping with getting this all going, because it takes a village. It takes a whole bunch of us to make it happen. Now, we are stronger together, which is what this brand is all about. And as we know, the Dental Codology Insider, as an insider, you're also welcome to be part of the consortium. And the consortium is the group of people that have, we're the ones that are in there creating the codes and submitting codes and having an active place at the codes committee. One of our goals is and has been that there needs to be representation of all the professions: hygiene assistant, business, dental therapy, and medicine on the dental code committee. Right now, the current makeup is not that at all. And we have been out there making our efforts and getting our voices known so that we can get a seat on that committee. A big step was taken just a few weeks ago. Patty Beeson and I, with Ann Buttrell from ADHA, met with with a couple of the staff members at ADA to talk about how we get the prevention voice on the codes committee. Now, one thing to point out, and I have the list of the organizations that are there. They're all, as you can see, they're organizational representatives. And therefore, that's where we're working in conjunction with ADHA, Hygiene Association. We're more than happy with the assistants and office managers too, but to get a member on there. So ADHA and DCC together, and our goal is to get ourselves on the CMC, the Code Maintenance Committee. A lot of letters there, huh? Anyway, we need your help. We need your help. When we met with ADA, we kind of went through a process of deciding, of just discussing what we need to, how we need to present ourselves. It's the Council on Dental Benefits that will eventually make the decision. And what we need to do is clearly describe why we should be on that committee. What do we bring? What do we bring? And this is right up here, and I don't expect you to read it now, because what I'm going to do is I'm going to be sending out a Survey Monkey within the next couple of weeks. And I know it's the holiday season and all, but I'd really like to get your perspective, because, again, we're stronger together, and we'll come up with a better document if we come up with it together. And we'll gather the data from the Survey Monkey, from each of you. We'll put it together, and then our first draft goes over to ADHA, who will then put their part on it. And then the ADA staff said that they would review it for us before it gets submitted. So we're trying to get the best document possible. It's about brevity. We don't want to have more than a single page document, because it's all about how much they'll read or not. But we need your help, and I'm going to invite each of you to share your thoughts on what's important. Now, we are in the countdown to the codes meeting. The meeting will be at ADA headquarters on the 14th and 15th of March. Now, what happens quite literally for the last 7-8 years, they've only met a single day. So my guess is that the meeting will probably only be on the 14th, but it's still listed as 2 days. If you can come, as we've talked about before, your presence is there. It is an open mic. Anyone can testify, and we're looking for people that want to share their voice at that meeting. Now, we're also in another part. Because we want to be on this committee, we want to behave as if. What does that mean? Well, if we were on that committee, we would be voting on all of the submissions. And one of the things that is sometimes seen by some people is that we are not qualified, particularly as hygienists or assistants, to vote on all these things because we don't know enough about all the things they're going to vote on. And so what we've done for the past 3 years is we behave as if. We go over all of the submissions and decide how would we vote on them if we were a voting member. Those will be, as you can see, the date is the 16th of December when that inventory goes online and we get access to it. That's why our next meeting, again, behave as if, is on January 5th, because we're going to begin to discuss how we would vote on these submissions. We have no idea how many there's going to be. We don't know until it's published. We know our group submitted 12, but we don't know how many others. Last year there was 145 or something like that. And a lot of submissions. So again, what we also understand is that for people that want to go to the meeting, it costs money for you to travel to the meeting, to take off work and all that. So in coordination with Hygiene Association and our group, we are putting together a travel grant that we're going to announce the details of how you apply for it, how you get it, how it's going to work. We'll be announcing that at that meeting on January the 5th. So we're putting a lot of things together in the background here to make this group even more successful. This is 3 of the codes, 3 of the submissions that we had. Again, thank you to Susan Cotton for chairing the group, the oral cancer screening group. We came up that we wanted to have an enhanced oral cancer code, and we wanted to take it out of, in case you hadn't seen this before, we want to take the language out of the comprehensive oral evaluation, periodic oral evaluation. The reason we want to take them out of there is because we still don't believe that people are doing the oral cancer screening. And there's so much more than just a screening, which is exactly why Dr. Maples is such a great speaker for tonight. Again, before we go into the next part, when I'm going to hand the screen over to Dr. Maples, please mute yourself. If you want to talk and ask a question, it is a mastermind and we want to talk, please, you can unmute yourself, but we want to keep all extraneous noise. Also, again, if you haven't done it already, put your full name in the chat box. And you can see the CE is already done. Although last month, I think I gave you a CE certificate that said 3 hours. It was only 1, but oh well, I'm not asking for them back. And again, we'll have a simpler system as we go further online with our new system, but that's what we have for tonight. Now, I want to thank Dr. Maples. Let me tell you a little bit about her. Dr. Susan Maples, for her, success has always been about passion, forward thinking, and never settling for good enough. You can see why I like her so much already just from that. She bought her dental practice upon graduation at the age of 25. After 7 successful years in general practice, she decided to pursue her master's degree in business, where she developed a passion for organizational behavior, executive leadership, and target marketing. After earning that degree, she began studying some of the top clinicians in restorative dentistry and medicine. As recognized expert in the mouth-body connections, Susan enjoys educating on cardiovascular disease, airway, sleep disorders, diabetes, acid reflux, HPV oral cancer, pediatric airway, lip and tongue ties, and the list goes on. I'm very honored and thrilled to introduce you to Dr. Maples. And I'm going to hand the screen over to you, Dr. Maples, and I'll let you take it from here. I'll get to find your name. There it is. Okay, you should have the screen.
All right, hold on one moment. Okay, here we go. Well, good evening, everyone. I'm so delighted to be with you. Can you see the screen now?
Yeah, we can.
Okay, and I'm wondering how I get rid of my stuff here. Okay, I can get rid of that. Okay, so 1 second. So I just want to say thank you for having me. It is my absolute, I go by Susan, by the way. And I would be happy to take your questions. To me, this will be a successful evening if you get out of it what you are wanting. And what I'd really like is to kind of rock your world a little bit tonight. And, you know, it is my pleasure and honor to be an influencer in this movement of total health or integrative dental medicine, total health dentistry, however you want to say it. What I will say is that my grandma had a poem on her refrigerator that said, you're sure you're right, how fine and strong, but were you ever just assured wrong? There will be some things I'm going to say tonight that are wrong, and I don't know what they are because I wouldn't be saying them if I knew. But the research is constantly changing, and if there'd been any way to predict what we're saying tonight 20 or 35 years ago when I graduated dental school, I would have fainted. I mean, it is, oropharyngeal cancer has changed so much in our lifetime, in my lifetime in dentistry. It's been exciting and disturbing at the same time. So let's dive in. Originally, and I'm not sure why I can't, let me see if I don't know why I can't advance the slides. So wait a second, let me find out. There we go. So in terms of screening, and somebody's like typing or thumping in the background, if you could mute when you're not asking a question, that would be great. But in terms of screening, I understand from Linda Miles that, I don't know, 17% of us are doing oropharyngeal cancer screening at all. Okay. And yet when I ask audiences, how many of you are doing this, they all raise their hands. So I guess we have different understandings of what that means to be screening. But most people, and if you're doing it, hopefully you're telling your patient, most people are doing this. They're doing this sort of 8-point screening, maybe 9-point if you're looking for nodes in the neck, and we're looking around. And we typically have been thinking that most of our oropharyngeal cancers have been showing up in the lateral border of the tongue, posterior third, or the floor of the mouth. We used to call that the death triangle. And those were related to what? Smoking, and especially smoking in the presence of alcohol, which would have exacerbated your risk levels. We hopefully check for every patient, and maybe we use a light. We have a light in every one of our operatories for people who are high risk for cancers in the mouth. And these lights illuminate lesions that we wouldn't ordinarily be able to identify as risky behaviors. The lights are a little tricky because while you're generally referring for biopsies, we're not sending the light with the patient, so the oral surgeon may have a hard time recognizing what we're referring for. But when we do this, and hopefully you're telling your patient, I'm doing an oral cancer screening right now, and most of us say, and you're good, it looks good. The fact of the matter is you're only screening for 30% of the oropharyngeal cancers today. 30% are going to show up in the mouth. And so 70% of the oropharyngeal cancers show up in the back of the mouth, the base of the tongue, the posterior pharynx, the tonsillar pillars, all the posterior tissues that are not visible to us. 70%, and those are HPV related. And so we consider 30% non-HPV related, although people who do smoke and drink alcohol are more prone also to have HPV related cancers. The good news about HPV related cancers is they affect younger people. The bad news about that is they affect younger people. But the mortality rate is lower, and what we typically expect is that people survive treatment a lot better than the non-HPV related, and that's typically because we're believing that's because it's age related. If you've been smoking and drinking all your life and you're 65 years old, you're going to have a lower chance of being able to survive the brutality of the treatment itself. Again, whoever's in the background walking or doing something, if you could mute, that would be great. Okay, so what becomes more important in the let me just go back. These 70% of non-visible cancers are the ones that we need to talk about because the smallest lesion, 1 to 2 millimeters, could result in a deeper cancer that affects lymph nodes. And we're talking about the neck, which is the whole mediastinal area, right? And what we typically see is that these lymph nodes are what we call neck disease. They pop out in the neck, and that's the first sign you actually have a lesion. So you don't get a sore throat, you don't get a numb tongue, you don't get an indurated lesion that somehow makes it difficult for you to swallow. Generally, we typically see it in the neck, which makes this part of the exam, the neck exam, the most important part. Many of us have not been taught well how to do it, and we sort of overlook it. We use the tip of our fingers, and we kind of feel around in the neck, and we quickly go to the tongue, because the tongue is where we're supposed to be seeing this, right? Now, what we're really wanting is to look at the neck more carefully. So HPV is considered the most common STD, sexually transmitted infection, in the United States by a long shot, and actually worldwide. And HPV is generally caused the infection spread from oral sex. Oral sex isn't going away. So although this is one thing that makes it difficult for us to talk about, is because nobody really wants to hear about, oh, what happened to my slide? I was trying to move, okay. Nobody really wants to hear about oral sex in the dental chair, and especially dental hygienists aren't really wanting to talk about it. So we typically overlook it, which means we're not even asking on the health histories if they've been vaccinated or what they know about it, or are they interested in an HPV test. So we'll talk a little bit more about that. According to the CDC, 80 million Americans are affected with some type of HPV. In fact, if you put Scotch tape on the back of your hand and arm, anywhere on your body, and pulled it off, you'd have HPV there. It's insidious. It's everywhere. It's the same family of viruses that cause warts on your fingers, or plantar's warts on the bottoms of your feet. Although there are 200 different strains of HPV, and not all of them cause cancer, of course. And so we typically think that this is so common that nearly all men and women will get at least one type of HPV at some point in their lives, and much of it is sexually transmitted. So we'll talk a little bit more about that. The current facts that I'm talking about in HPV-OPC come from this trends in human papillomavirus associated with cancers in the U.S. Up till 2015, published August 24th of 2018. So these are the latest CDC statistics. 2015 data shows that there are more oropharyngeal cancers than cervical cancers caused by HPV. In other words, we've always heard HPV associated with cervical cancer. When they first started vaccinating, we typically vaccinated girls, and then boys were sort of like, well, they were the carriers, so it wasn't important. They never talked about penile, anal, or oral cancer in boys. They really were talking about cervical cancer. But here you can see that there's a third more oropharyngeal cancer than cervical cancer already, and increasing at about 30% a year. Unfortunately, or fortunately, this is a horrible statistic, but it's affecting 82% men and only 18% women. And so while we often thought it was the woman's disease, and therefore we saw a lot more girls get vaccinated than boys, now we're seeing it's 82% in men. The thought there is that white men, which is the biggest demographic, white middle-aged men actually, that white men have the highest number of lifetime oral sex partners and report first oral sex at younger age compared to other demographics. And what I look at there is right now in the US, it's reported that 10 to 13 years old is the average age that a child might first engage in oral sex, which to many of you, you're mortified right now thinking of your 12-year-old child, but it's considered very casual now. Oral sex as a society has changed to be considered safe sex because it's not impregnating, and we're not recognizing and talking about the fact that it really isn't safe sex. This is a cancer risk. And so when you're talking about multiple partners, you're increasing your risk for sure. But 50% of new HPV infections occur in the ages of 15 to 24 years old. This is not when they get cancer, this is when they get the infection. And then the persistent infection is what grows to cause that risk. So the vaccine, which up until last year was 4 strains of the most significant cancer-causing viruses, is still today not reaching half of US kids. So we are way under the wire, and we're not going to see the trends in this increasing cancer turn around until we start getting the entire population vaccinated. And the vaccination target age is 11 to 12 years old, which makes sense. There are many physicians that, because it's not required, they're not talking about it. You might think it's ridiculous to talk about an STD with an 11 or 12-year-old that they're assuming is not having oral sex, and they're not necessarily. There was some talk that many physicians thought that if they gave the child this vaccine, that it would be promoting sexual contact between children, and I think that's ridiculous, but that's been some of the reason why we haven't gotten the word out. And I believe that because oropharyngeal cancer is in our domain, that we ought to be promoting this also. A really, really good study, and I don't have it in this particular report, shows that families are more likely to have their kids vaccinated at the recommendation of their doctor, including their dentist and hygienist, so we ought to be recommending that. The FDA expanded the Gardasil vaccine to cover adults to age 45 in 2018, which means they're paying for it up to age 45 for most insurances. I'm almost 60, can't go out and get the vaccine. You just walk into your Rite Aid and ask them to be vaccinated. It's a series of 3 for adults and 2 for children. But it's important that we spread the news that for all those people that missed the vaccine, they've increased the age to account for the increase in the oral in cancer. The problem, well, let me stop there and address that in a little bit. But the CDC says that HPV vaccine prior to becoming infected covers the potential to prevent more than 90% of these cancers. And that's a really important statistic to remember for your patients. So Merck, the manufacturer of the vaccine, still has not received FDA approval to discuss oropharyngeal cancer related to this vaccine in their advertisements. So you never hear it on the radio, even though oropharyngeal cancer outnumbers cervical cancer, penile cancer, and anal cancer together. We don't hear about it because they're not allowed to. And every year it's like, this is going to be the year the FDA is going to allow this, and they don't. So I'm not really sure. They want generic, they want their own research based on just oropharyngeal cancer vaccine. What we do know is that it now covers 9 of the valent. I'll show you that in a minute. Let's keep going. Saliva is the future for fighting HPV cancer because we can detect the virus in saliva. And when we see the vaccination, the Gardasil vaccine was for these 4 types of HPV, and now the Gardasil 9 covers these. What we know is that the mouth is a home to 25 different, let me see, let me go back. The mouth is a home to 25 different HPV strains, and I'm sorry, 51 different HPV strains, and 25 of them have been associated with oral cancer. So even though these 9 are the most oncogenic or cancer-causing types for cervical cancer as well as oral cancer, by spitting in a cup and testing which HPV strains are there, we can also help predict how likely these infections are to go on to create cancer. So when you do have a positive HPV test, in other words, if I were to spit in a cup and get this information back from oral DNA that I had HPV-16 infection, I would not necessarily say that I would be prone to cancer at that point. It certainly would have me a little nervous, but we'd want to retest in 12 to 18 months because it is the persistent infection that really goes on to cause a problem. At that point, it's probably fair game for us to want to get a laryngoscope in the back of our pharynx and look around for lesions more frequently. There isn't a protocol on that, but I was speaking at the Washington Medical Dental Summit with a guy named Guy Jones, who's an oral oncologist, And I said to him, so Guy, if you knew you were HPV positive orally, how often would you ask your partner to stay after work and spray some anesthetic and scope you? He said, probably every 6 weeks. So there is some, need for us to do some more research to find out what do we do after. Do we just wait for a neck node to pop up and say, oh my gosh, we're diseased? Or once you know you're at risk, what do you do? One of the positive benefits of recognizing that you're at risk for oropharyngeal cancer is that this is one of the viruses that does clear. In other words, you can clear a common cold or a flu virus. Now, the old adage, so there's some viruses you don't clear. One of the old adages is, what's the difference between herpes and marriage? Well, herpes lasts forever. That gets a bit of a laugh in audiences. But the fact of the matter is there are viruses like HIV and herpes that stick around and store themselves in the body in various ways. And HPV can actually clear, but you need to treat your body like a temple. You don't want to be partying like a rock star. Part of the reason we see the 50% of new cases in 15 to 24-year-olds is that this is the age group that also is more prone to mononucleosis. They're not sleeping. They may be partying a little more than normal. They're also have multiple sexual partners. They don't necessarily take as good a care of themselves nutritionally as they might when they're in their primary homes or even later. And so when we look at the opportunity for people to know whether they're HPV positive, we also look at their ability to help themselves clear the virus by living a healthier lifestyle. HPV is associated with improved survival in the posterior pharynx, oropharynx, hypopharynx, and the survival difference was associated with overall, the overall survival rates have been associated with early diagnosis. And when we look at routine testing for HPV, we think that this may be warranted to help with long-term survivability, just to get a kind of a jump on it to look for more risk factors. So when we look at the tests, the oral risk test for oral DNA, this is just one of the HPV tests. This is the one we use. It's pretty easy. They test for 51 of the 200 types of HPV. And when they identify these 51, any one of those, they run the sample again. So it's a really, really hyper vigilant, accurate test. When they run the sample again, they pull out 25 of the oral cancers that have been associated with oral cancer. I'm sorry, 25 of the HPV viruses that have been associated with oral cancer. So even though HPV 16 and 18 are the highest risk, any of these types that persist beyond 12 to 18 months, we consider high risk for HPV-related cancers. Again, sometimes you'll get the test back and it'll say it's inconclusive, meaning that there's presence of the HPV virus, but it's unrecognizable. The body is likely degrading the virus and it's in the process of getting rid of that. For any of you that ever tested positive cervically during your pap smear, they take an HPV test and you're HPV positive 16 and you think, oh my gosh, I have HPV 16, and then the next year or 2 years or 3 years later, they test you and it's gone. This is what we sometimes see. So again, the 9-valent HPV vaccine targets the same oncogenic types attributed to 73% of HPV-associated cervical cancers, penile cancers, anal cancers, and oropharyngeal cancers. These are all the most, again, the 9-valent vaccine covers about 73% of the HPV-associated cancers. I sometimes, and again, it's really hard to make this judgment call, but I tell families, if your child was vaccinated at 11, 12 years old, and now they're 25 years old in college, what's to stop you from getting that third dose at 25 that gives you an extra 5 oncogenic types? And so that's sort of become a little bit of a recommendation, even though the CDC doesn't necessarily say that. I think that that makes sense to me. That age group gets 3 vaccines. The younger age group gets 2. But if they only had the original Gardasil, now they can get 5 more. So we talked about, again, emphasizing the importance of boosting host immune response and clearing HPV by increasing the quality and quantity of sleep, nutrition, and reducing your just drugs and alcohol and, just a haphazard lifestyle. So in our practice, every year we do a big health campaign. And one of the things that we weren't doing well, we do a lot of total health dentistry extras. We do, we test for reflux, and we test for diabetes, and we help people with weight loss, and we identify vitamin deficiencies and food sensitivities, and we do sleep tests, and we do pediatric airway. And one of the things we weren't doing well is talking about HPV. And I would say to my team members, it's not that hard. I mean, you just talk about it when you're doing the oral cancer screening, but they typically were avoiding it. And so I said, well, here's what we're going to do. We do a health awareness campaign every year, and it's something different. And for 2 years ago, we decided we were going to do an HPV awareness campaign. This is the front and back of a placard that we gave patients to learn more about what we wanted them to know. And so we targeted 100% of our 18 and olders. So all of our adult patients, we wanted them to know the risks of HPV oropharyngeal cancer, that oral sex wasn't safe sex, that they could be tested if they wanted, and talked about the vaccine, and also talked about paying close attention to the neck. It turns out, since 83% of these cancers, or 82% of these cancers, are in men, what's the first indication is generally, again, a lymph node. While they're shaving, they notice a lymph node pop out and go, wait, what's that? And that's generally one of the first indications. So we wanted to educate our patients about this. And so we targeted 100% of our patients. And in doing so, we got really good at talking about it. We also had some really tricky questions coming our way that we couldn't answer. And some of the questions that we were asked really can't be answered because the literature isn't there. The support isn't there. A lot of what we were asked is, well, I've already been tested and I'm negative. If I have it cervically, I can't have it orally, right? Wrong. And we were asked, well, I have it already vaginally, and can I transfer it to myself orally? And the answer wasn't clear on that. So, I met with some experts in this area of epidemiology to take a look at that. And again, in some areas, the research is pretty thin and we have more to go. But unfortunately, we're going to lose a lot more people. I've been fortunate my entire career to make it through about 30 years of practicing dentistry without a single squamous cell carcinoma diagnosed. And in the last 2.5 years, we've had 4 oropharyngeal cancers, sadly, and 2 of them are good friends of mine. It's an absolutely brutal, brutal treatment. You have to generally get an NG tube because by the time they radiate your throat and neck, it's, the tissue sloughs and gets stuck in the epiglottis, extremely painful. The saliva goes away, they can't swallow, they can't eat. It's, they become, and of course you're nuking the tissue, so you're really having to heal along with that, which increases your basic metabolic rate, and they get very, very thin, lose their voice. I mean, it's really brutal. I was sitting on an airplane next to a head and neck oncologist, and I said, it feels like next to brain cancer, this would be the worst. And he said, oh, no, way worse than brain cancer. Brain cancer, we typically subdue it with some steroids, and people typically fade out a little bit, excuse me, and they get through it okay, whether they live or die. But this is brutal. So it is not something you'd wish on your worst enemy. In any event, we brought awareness to 100% of our adult patients, and they signed these placards that went into our vestibule outside our office. And when they signed this with their first name, if they decided to take this saliva test, we we put a stamp on it that says, like up here, if you can see that, I was tested. And many people did get the test. I think the test is we charge $115, and I can't remember what Oral DNA charges us. But in any event, it's a really accurate test, as I said, but it's weird as a dentist to have to call people and give them the news that you have a sexually transmitted disease and infection, and that we'd want to test them again a year later. But people really appreciated it, knowing, and then all of a sudden we're more astute and wanted to learn more, and so we learned more right along with them. I'd bring this up because there was a big article published in Dentistry Today just this year in the Oral Cancer Awareness Month. I can't remember what month this was, and that picture's a little blurry, but I wrote an article for them on talking points of how to discuss it and make it easier. And when this was published, I got a call from a speaking engagement that I had with a large DSO that had hired me to come in and speak for a full day on total health. And I got a call from the guy inside the organization that hired me and said the CEO isn't sure he wants you to come and speak. Apparently, he didn't like the title that said Oral Sex and Oral Cancer, Our Turn to Talk. And he was like, this is not a woman we want representing our organization. It was a very conservative organization. So I said, that's fine. Just, it doesn't matter. Just take it away. I have to fly from Omaha to Nebraska or to Dallas the next day. And he was like, no. I really, really want you to speak, but you have to talk to the CEO. So I said, all right. Well, you set up this talk about a month later. When he got on the phone, I said to him, look, I know what you're calling about, and if you don't want me to mention HPV, I have 28 different subject matters. We don't even need to talk about it, but it is our problem. And if we're not going to talk about it, who will? And then I named some statistics, and about 5 minutes into the conversation, the CEO of this company stops me and he says, I want you to come and I want you to talk about anything you want to talk about. I'm fine. I'm embarrassed. I should have gotten on the phone with you earlier. And I thought, wow, that was easy. So when I got to talk in front of the group, and at the very end of the day, they got up and said they were going to have me back to speak to their whole, bigger consortium. This was just the doctors, and they wanted me to talk to the rest of the staff about things. And he said, this day almost didn't happen because I read this article and I was so put off by the title, I didn't even read it. And he said, Susan, you probably don't remember what it was that you said that changed my mind that day. And I said, I don't think you ever shared it. And he said, you said, if we're not going to talk about it, who will? And he said, you're absolutely right. No one's talking about it. And this is an epidemic increasing at 30% a year. And it is in our domain, and we ought to be talking about it. So I thought it was just such an amazingly humble and awesome demonstration of leadership. But I also really, really believe that we ought to be better at talking about it. And that I think the rest of the world believes that too. Our patients really appreciated it. And anytime you're doing something cool, you want to tell on yourself. So I just wanted to play this. I don't know.
We can't really hear it, Susan.
Okay. So maybe you can include it. It was a very long news alert from Channel 6 News that played 4 times, talking about the campaign and how, out of the people that were tested, 1/3 of them were positive, and what a difference that made for them. And so anyway, hopefully when we embed it in there that you'll be able to click it on your website. But it was a neat news publication and got the word out, and through that Lansing Community College ended up having a testing zone, and we sort of helped with that. So that's kind of what I have on that. If you want to learn more about any of these aspects and how to really integrate them into practice, my big thing is not just learning the science, but integrating the science into action so that it enters the hearts and minds of our patients and that we're able to truly impact their lives rather than just learning it on a webinar and thinking, oh, that's interesting, here's what I found out. But how do we really bring this home in a way that can change lives, save lives, and turn this epidemic on its ear, which won't happen until we're really fully vaccinating patients. my hope is that dental offices will be vaccinating kids before long, because it's affecting, again, oropharyngeal cancer more than any other cancer, and that there isn't any reason why we shouldn't at some point be vaccinating. If they can do it with the nurse practitioner or the physician's assistant up at the Rite Aid on the corner, we can certainly do it in our dental offices too. If you want more information on how to bring all of this to your team members, Total Health Academy, which is an online learning platform for 60 different areas of total health, you can take a look at that, totalhealthpractice.com, or just Google Total Health Academy and take a look at that, and you'll see that these modules are available for online learning so that you can bring this home to your team members as well. I believe it takes a full effort, and it's really hard sometimes for the dentist to do all the influencing with their team, which is why you're here and why we have educational resources like Patty's and others to help with that. This is one of my favorite quotes, and I just want to say, even though we have a small group tonight, I never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. So I want you to know that I'm here for you. This is my team cheering you on, helping you, answering questions, and that is my personal cell phone number and my personal email, and I'd love your feedback on tonight or any other questions you have on total health or oral systemic health or airway or any other issues you have. This is the future of dentistry. Right now, it's really considered a niche because there are lots of people who do not trust the healthcare system to bring them health. The only thing missing in healthcare today is care and health. So, yeah, it's sad, but it is the truth. And we're in a position, instead of just being early detection, cavity finders and periodontal probers and pulling out and finding a lesion, we're in a position to actually predict and preempt so much of not just oral disease, but metabolic disease and systemic disease in general. And if we could use our 6-month preventive relationship to truly be preventive, not just early diagnostic, but truly be preventive, we would take our rightful place in this healthcare crisis like no tomorrow. And in the meantime, we have lots of patients who are seeking optimal health, who will find you. They are the kind of people that spend their own money on health. You'll increase their trust level just by the work that you're doing, the questions you're asking, and uncovering root cause for a lot of their problems. And they will absolutely increase your case acceptance. They'll spread the news in the community. About 40% of our patients right now are coming from the medical community, physicians and their patient referrals, which is not easy to get, but it's such a wonderful thing to be the go-to people in the community for this arena. So it is really considered a great way to avoid more and more ties to insurances. Our practice is a non-participating practice, and we have no insurance assignments whatsoever, even Delta Premier, and our waiting list to become a new patient, I think our next availability for new patients is end of April. So it's really a nice niche, and if you're interested in more about that, certainly reach out to me and talk to me. This for me is just a complete labor of love. I love what we're doing, and I'd love to help you jump into that fold too. And now, since we have just a couple minutes, if there are any questions that came up, I don't know, Patty, if you can tell, or
I can. Well, I know Susan had a comment about the HPV test, but before that, what I'd like to ask you, as people know here, that my work in codes is much less about insurance and more about the metrics. Are there codes that, because the CDT codes are our standard code set for our electronic health records, whether we have any kind of benefits, whether we accept any kind of benefits or not. Is there, from your perspective, Susan, codes that you would like to see that currently don't exist in the dental realm?
Absolutely. I think a code for HPV testing, which we make up a code and just develop, but we don't get any coverage for it. HPV testing would be great. Now you're going to get pushback because people are going to say, even the ENT world, what good is HPV testing? It's not a cancer test. It's presence of a virus. But I gave you lots of reasons tonight why it's important to have that awareness. And I think that that would be a really, really good one as well. I think when we look at the ENT world, we need to be looking at codes and protocols for early scoping, which doesn't really impact us. At some point, I think it would be fair game for us to be able to do some, use a flexible laryngeal scope and look for lesions in the back of the throat. It's just beyond our reach, and I think at some point that'll be in our realm as well. But right now, I think HPV testing, and I think that we also ought to be pushing for instance, we now have a code for A1C testing, which we do all the time in my office, right? And most people would be like, you're testing for diabetes in your office? Absolutely, because there's a bidirectional relationship with periodontal disease. It's important to know if your perio patient is hyperglycemic. Otherwise, because you're not going to be able to win with that patient unless you're addressing it. Plus, we never really want to introduce a surgical wound into a diabetic patient, unknown diabetic patient. So we shouldn't be scaling in those deep pockets anyway. So that's an example of how we use it. And I think that, again, the future is bright, but we definitely are, it's not going to happen in my lifetime that dentistry is flexible and nimble enough to jump into some of this. So, too many people, maybe even on this call, you're thinking, oh my gosh, this is way out of my scope of practice. I'm not comfortable with the thought of ever giving a vaccination shot or with the thought of ever putting a laryngeal scope in the back of the throat, spraying a topical anesthetic and looking further than just the mouth. The mouth is its own entity. Why do we have to go back there? You know, so I think putting the mouth back in the body means that we have to have a collaborative interdisciplinary approach, and that we get out of our comfort zone a little bit too. Stop doing what we've always done and thinking it's good enough. And if there's anything you've learned tonight, really stop thinking that the oral cancer screening you're doing by looking around the mouth and pulling the tongue out and looking at the floor of the mouth is a definitive oral cancer screening, because it really isn't.
Susan, can you talk about what you wrote in the chat box about what your understanding is, the point of view of the HPV test?
Sure. Yeah, some of the experts I've talked with, I attended a symposium by MD Anderson and talking with the Oral Cancer Foundation experts there. When talking with them about the HPV saliva test, they said they are not recommending it because it shows that one moment in time. A person can test positive for it one moment in time, and it could be that next day your body might clear it.
Oh, not in a day, not anywhere close to a day, but you can clear it. Why would we want it cervically then? Why do we want it cervically?
I'm just reporting what they said.
Yeah.
And then somebody could test negative, and they could the next day be exposed to it and then have the infection. So what they're saying is that, it's just not definitive enough because it's that one moment in time. And if somebody does test positive for it, they're tested again, maybe 6 months later or so, and it comes back negative. That doesn't tell us if the body has cleared the infection or if the infection is dormant.
So if you have, they're recommending testing 12 to 18 months. And it, again, is the persistent infection that moves into the cells that causes the cancer risk. So people who develop oropharyngeal cancer aren't clearing the virus. The virus moves into the cells and takes over the DNA. In other words, so yeah, I've heard every argument both directions about why or why not we would consider HPV testing. But my question to you or to them is, why are we routinely doing it cervically then? Because that's the same thing, right? It's just a moment in time, I guess.
Question, isn't it?
Right, and we're doing it routinely because what we do know is that if you're HPV positive cervically, they recommend a pap smear annually until you clear the virus, and then it might be every 5 years depending on your age. So at that point, they're saying the HPV presence is more important than the pap smear in terms of recommending a pap smear to look for dysplastic cells. So in my mind, even though an oropharyngeal laryngoscope or a flexible laryngoscope is looking for lesions, not scraping a lesion to look at it under a microscope, it's not the same as a pap smear. It certainly would be worthy if I know, like as I said to Guy Jones, who's a really famous oral cancer or head and neck cancer specialist, I said to Guy, if you knew you were HPV-16 positive and had a persistent HPV-16 infection, how often would you have your partner look back there? He said every 6 weeks. So, you know, I guess there's an argument for both. But in my mind, I think it also lends awareness to the idea that, you know, you could put yourself in an ideal healing situation, which would increase your odds of clearing the virus rather than having it stick around long enough to cause cancer. Because it isn't the cancer, it isn't the HPV virus that disappears over time that causes the problem. It's the ones that don't.
Right.
Yeah.
It appears to me, too, in my experience, that when we have these new testing realms, or newer to some people, it's like they want perfection before we can accept it. Yeah, we'll stay with a lousy Explorer that's got a 45% accuracy,
Yep.
probing that's got less than whatever. It's absolutely ludicrous in my mind that we're arguing over these nitpicky things. If what we were doing was working, then fine, but it clearly isn't.
Yeah.
And so that's where it's like,
yeah, we have more middle-aged men with oropharyngeal cancer than all of the female population has cervical cancer.
yeah,
Just in that one segment of white middle-aged men. It's unbelievable. So again, it's not working. And, you know, we don't have time to catch up with the virus. We have to use whatever we can.
yeah.
And I also would recommend hiring your local or asking your local ENT to come in and teach you guys, your team, how to do a good neck exam. Because it's something, if we ever learned it, we unlearned it somewhere along the line. So it's a good idea to learn it and to practice on each other and to know what you're looking for. How hard do you palpate? Where do you look? Where would you see these lesions? Because ENTs are seeing oropharyngeal cancer all the time now.
Patty, I have a question. Well, thank you, doctor, for this presentation. You just give me hope that there are dentists that think the way that you do. I kind of have a statement and then maybe a question. One thing that frustrates me is that when we are referring to a cancer screening, we call it oral cancer screening, and it's not that. It's head, neck, and oral cancer, and I separate that. I don't think that head and neck falls under oral cancer. And so, you know, I've been in practice as a hygienist for almost 12 years now, and it's always referred to just the oral cancer screening. And you're right, it's just, you know, looking at the lateral borders of the tongue and asking the patient to flip up the tongue, and that's it. And so I just wish that we would change the way we talk about it, and that would help spread some of the awareness and get more professionals to do it. My question is, so I'm also a delegate for the American Dental Hygienists Association, and last year there was a state, I can't remember what state it was, but they submitted policy for the American Dental Hygienists Association to advocate for hygienists for the administration of the HPV vaccine. Now, of course, it was rejected. And one of the reasons why it was rejected is because some other delegates were arguing that we can't support something that we don't know what the side effects are. And so I have a feeling that something like this may come up on the House floor again. And so if there's any advice that you can give to me to just kind of support this policy to be able to get it passed, because I think that if hygienists, we know that we are the gateway. And so if we can be preventative and get as hands-on as possible, why not? But unfortunately, I didn't know much about the HPV vaccination to be able to, speak in favor of it.
Well, let me just suggest to you that it's going to be a while. One of the things that we look at, because my practice is full of people that really are all about wellness, there are a lot of people that are anti-vaccination because
Yes.
there have been controversies on, whether it causes autism or what's that? Oh my gosh. Anyway, there's some other talk about what vaccinations are doing. Are they associated with heavy metal and toxicity and various things? But one of the things you have to look at is, what is the vaccination schedule for kids? Are we bombarding infants? I do think that there's probably some room to debate all this. This particular vaccine, unlike, I'm not belittling the shingles vaccine, for instance, but people generally don't die from shingles. It makes you very uncomfortable for some time and can actually cause some liver damage, I understand. But this is cancer. And it's a cancer that is brutal, and it's about 50% deadly. And it's not okay to say, oh, we shouldn't be in that realm because there may be some side effects. The side effects we haven't associated with it. Now, if you get online and you look for side effects from this, you're going to get on there's a bunch of mommy blogs and a bunch of posts. There's a lot of hype. But the fact of the matter is, are we at any more risk than the nurses giving the vaccines in the pediatrician's office or the nurses giving the vaccines at the local pharmacy? We're giving the vaccine to a population of people to try to prevent an oropharyngeal cancer epidemic. And does that mean that hygienists aren't able to give a vaccine like they are? I believe we ought to be elevating the hygienists to providers in themselves, and that we ought to be taking full advantage of the fact that hygienists are the only bastions of prevention left in healthcare.
Yeah.
They're the only ones that the public associates with a preventive visit. Now, I'm going to tell you, so much of what we're doing in that preventive visit isn't preventive at all.
That's right.
And you may, it's a misnomer, but the public is hoodwinked to think they're getting a preventive visit. And to the extent that we could make this into a preventive visit for health, we would have a really, really rich future for helping in this declining healthcare arena. And I believe that hygienists are the answer to that. They're the answer to the future, and nurse practitioners both, because they come at it much more from a caring model too. But I think hygienists who have these relationships, if we could expand their function and their knowledge to be able to predict and preempt things like prediabetes and diabetes and reflux and HPV-OPC cancers and cardiovascular disease, and the list goes on, I think we really have something. So
I'm going to make a couple of suggestions too in regard to what you were just saying. A book I found, it's a few years old now, but it's still a really good book. It's the HPV vaccine controversy: Sex, Cancer, God, and Politics: A Guide for Parents, Women, Men, and Teenagers. It was the best book I've ever read on really understanding where all of the different parties are coming from and why this has been a controversy. And I think if we're going to talk about it, it's important to be knowledgeable and understanding and accepting of whatever someone else's point of view is their point of view, because that's the beginning of having a conversation with them. We first got to accept where they're coming from, and it really covered it extremely well. That's one thing. In regard to what we were just talking about with vaccines, I was in a volunteer group after 9/11 and a few more of the tragedies that we've had in our country. It's become known to Department of, security, that if there's a disaster, the first responders teams, the hospitals, the physicians, the nurses are all going to be tied up doing first level things. And I was part of a DMERC team which tested how well we could give vaccines. They had, I think there was, I don't remember how many of us, there were dental health professionals that they put us into a public health setting, and we actually injected pork roast because we weren't actually injecting people, but what we were doing is they wanted to see how well we could do it, and what the research showed is we did it better and more efficiently than the nurses in public health.
I don't doubt that a bit.
We're completely capable. So even for there to be a controversy is laughable, really. It's the same thing as what we just said a little while ago about having that perfect test and the perfect this and the perfect that before we can accept something different. And as Susan just said so beautifully, that I think many of us on this call, because I know a lot of you, we've talked about, but the only way it's going to happen is for us to make it so. As I read last month in that article that I wrote, I'm not waiting anymore. I'm not waiting for somebody to give me permission or wait for it to be perfect. We're going to forge ahead, and we're going to keep pushing the envelope and make it happen, because that's how change happens.
I'm totally with you. I'm totally with you on that.
Yep. And this is the group to do it. This is absolutely the group to do it.
Yep, I love it.
So
I love it. Glad to be a part of this.
Patty, here in Colorado, we have an initiative through public health, which is called HPV Free Colorado. And they asked me to be one of their dental trainers as we go to different offices to talk about HPV, oropharyngeal cancer, and the vaccination. And that's one thing that we are definitely advocating for, is dental hygienists and dentists being able to administer this vaccine. And we're giving these offices the tools to talk with their patients about the vaccination and about HPV. So in Colorado, we're jumping on it.
Moving forward.
Susan? Either Susan. I've noticed that in my experience, dentists are very afraid of leaving the mouth. They feel like it's outside of their scope. They're not supposed to discuss anything but that hole in the tooth. And how do you change their mindset?
My issue has been that dentistry's changed so much towards pressure on productivity and profitability. And there is a lot of oral disease. So why not just shut up and drill? You know, if you can make money drilling, why do you need to stop and talk about anything else? And that frustrates me to no end, because where did our heart go in this? Where is our care? So I get frustrated, but I also see, you know, particularly when I go to a beginning audience, an audience that's sort of like testing the waters on all this, and I'll find a few people that are passionate, and some people are sort of scratching their head. But I find that my more advanced audience is people that are down the road a pace with this and want more and more and more of it. They are really, really reignited around a passion for helping people. They remember why they got into this to begin with. They love the work they're doing. And I think a lot of it is we've forgotten who we're supposed to be. We're healthcare people. We're supposed to care about people, and we're supposed to care about health, not just sickness. And I think that it's going to be a long while. I think people are afraid. Change is hard. I say we're like a group of Boy Scouts and Girl Scouts. We're rule followers to the nth degree. We like to learn a protocol. It's a paint by numbers system. You know, you etch for 60 seconds or 10 seconds, and you rinse and you apply this for, and then you do this and you do this, and it all works. And we just repeat that over and over again. And that's the way we do our examinations. We say, any changes in your health history, to which the patient replies no. And you tip them back and you pull the tongue out of the mouth and you look around there, and then you pick up a probe, and then you pick up an explorer and look for caries. And that's just the way we learned it. That's just the way we're going to do it. And I just think it's so tragic that we've stopped thinking that we're just doers. When you go to a physician, they at least have to take in the patient's chief concern. They only get 7 minutes to talk to them, and they're going to go in a different direction depending on what the patient brings them. They're at least having to think about the person for a moment versus doing something so routinized that you could fall asleep doing it.
And
So
that's
anyway.
really what we were talking, when I was talking about what Kathy and I are putting together on the idea of medically necessary coding. Medically necessary is the key, and the very beginning of that is, what is the patient's chief concern? We don't even bother to mess around with that anymore. It's like we don't ask, we don't listen. They share with us, and we ignore that part. And it's a dentist is obligated, is a medical practitioner, because the federal government, we redefined from CMS, redefined a physician. A dentist is a physician, and we're obligated to make a medical diagnosis at every patient, and we shouldn't be doing treatment unless we have a medical diagnosis.
Couldn't agree more.
And the dental hygiene diagnosis is part of that dental medical diagnosis. Huge players in it.
But it's not just perio. When you see
Oh my God, no.
you see red gingiva that isn't a border of red gingiva from plaque, you're automatically thinking, all right, what's going on here? Is this candida? Is this zoostomia? Is this a food sensitivity like the caseins in the dairy, or like gluten? I mean, what is it that's going on here? When you see a fissured tongue, why is it fissured? Is it dry mouth? Is it B12? A deficiency? What is it that's going on? It's up to us to sort of get to root cause, not just to write it in your chart, but to help the patient figure it out.
Yep.
When you see things that are sort of out of, All right.
Fantastic. Well, thank you so very, very much. I will put a link to that video in the newsletter, as well as, again, I put the book that I mentioned already in there. And remember, it's Total Health Academy. Go look at it. Let's go see what Susan's doing, and let's join this movement. We are part of this movement.
I love it. And I'll put a plug in for AASH coming August.
Oh, yes, AASH too, American Academy of Oral Systemic Health. Yeah, you want to get a hang with like-minded people, boy, that's where they hang, guys.
Right.
That's where they hang.
And if I can help you further and speak further, or show up at any of your local speaking,
for sure. And again, when it
any other
comes,
subject, let me know.
and if you have codes that you can see that would be helpful for the important metrics. See, it's about the metrics that's so important. That's why we want to have that enhanced oral cancer screening code. We need it. We need to have an HPV treatment code. There we go. We got one of our groups already for next year. So let's keep it going, guys. And until our next time, remember, January 2nd is our first DCC to start talking about what was submitted. It will be interesting because there have been, the code committees aren't quite as backwards as they seem. We do have the we have the HbA1c, we have the glucose testing, we have caries risk assessment codes. There's a whole lot more needed, and we're gonna see what that is and start looking at that January 2nd. And then, of course, with our wonderful Siobhan Healy on the 14th, and you'll be getting, and watch for the exciting stuff that's happening online. You'll be getting lots of information from me. Until then, I wish you all a very Merry Christmas, Happy New Year.
You too, Patty.
And
Thanks for all you do.
See you online. We're making a difference together.
Okay.
Good night, everybody. Thanks.
Bye-bye.
Bye.